Hi, I'm Cesar Rodriguez, and I am a myeloma doctor at the Icahn School of Medicine at Mount Sinai in New York. And I'm presenting the data on the poster Daratumumab plus lenalidomide-bortezomib-dexamethasone and transplant-eligible newly diagnosed myeloma. This is a post-hoc analysis of sustained MRD negative status in the GRIFFIN study. And the data here in a summary is all of the patients who participated in the GRIFFIN study and completed their 2 years of maintenance or had to be removed and had a median follow-up of 38 months, we analyzed the study arm and the control arm. Study arm having daratumumab incorporated to the RVD induction, consolidation after transplant, and len maintenance versus control arm using RVD as part of the induction, post-transplant consolidation, and just len maintenance. And we saw that with this post-hoc analysis of sustained MRD negativity, that there in all of their clinically relevant subgroups in the GRIFFIN study, which included patients above the age of 65, ISS stage 3, high-risk cytogenetics, and revised high-risk cytogenetics, which included 1q gain and translocation 14, did better in the study arm compared to the control arm. This was at 10 to the minus 5, which was the secondary endpoint of the study. And there were some variability when looking at high-risk cytogenetics, part, in fact, because of the fact that there was such a small amount of patients that had high-risk disease, which requires further evaluation, which we hopefully will be getting all that data from the Perseus studies, which is a phase 3 study using DARA RVD versus RVD as part of the induction consolidation, and then adding DARA to the len maintenance in patients undergoing transplant. Now, when we look at the 10 to the minus 6 threshold, MRD negativity rates at 6 months or higher and 12 months or higher were higher also in the daratumumab arm in most groups, except for the revised high-risk cytogenetics, including the gain 1q. And that is also in part because it's a small sample size and it's not powered to have data for the high-risk disease patients. We also saw that PFS was consistently better in the daratumumab RVD subgroup compared to the RVD control arm in patients who achieved durable MRD negativity at the 10 to the minus 5 threshold, which suggests that all the patients who do achieve a sustained MRD negative status at 6 months or 12 months translates to a more prolonged PFS. And when comparing the control arm and the study arm, we see that the study arm had a longer PFS compared to the control arm. So in summary, we see that the addition of daratumumab to RVD induction, consolidation, and len maintenance can improve the rates of durable MRD negativity. That also leads to improved PFS among relevant subgroups in the GRIFFIN study. And it's something that we need more studies to try to determine if this is going to be beneficial also in a high-risk group, and if 10 to the minus 6 is something that we should also be pursuing in the future. But the trends are generally similar in both arms in terms of the sustained MRD negativity translating into prolonged PFS, although we are seeing a big benefit in the daratumumab arm when it comes to the depth of the response and a higher degree of sustained MRD negative status.